Hi there. We are looking at chapter 16 today, female reproductive system. We just talked about male. I'm going to warn you, this is a very long chapter because they don't just talk about the reproductive system, they talk about pregnancy, they talk about the process of birth, they look at lactation. I mean, it's much more complex than the male version, so it's quite long, and I'm going to have to really kind of keep this to a high level discussion. I need you to go back to the textbook and do some additional reading and take notes, just because it is such a dense chapter, that we'll be here for 4 hours discussing this, if we needed to, if we could, but we can't. No one wants to listen to me talk that long, and it's just not effective. So I'm going to do what I can here to give you a high level version, and you're going to have to go back to the textbook and take a look. Anyways, so really quickly, learning objectives, we're going to look at the female reproductive tract, look at some of the functions of the parts. As we go along, we'll describe the structure and function of the mammary glands. Mammary glands are not technically part of the reproductive system, but they're intertwined so heavily with birth and the hormone system associated with the reproductive system. We tend to lump them all together. We're going to talk about the menstrual cycle. We're going to talk about contraception and some examples. We're going to talk about disorders, clinical disorders of the female reproductive system. We're going to talk about what happens to a fetus or an embryo within the first couple of months after fertilization. We're going to talk about the placenta, the role of the placenta. We're going to look a little bit into the concept of some issues around fetal circulation and some of the adaptations that take place and what the reasoning is. We're going to talk about childbirth. There's a good video that I've included into our module this week, so take a look at that. It's going to be more detailed than what we can do. We're going to look at some of the endocrine system and the nervous controls that are associated with lactation. We'll look at, obviously, some of the medical root terms associated with chapter 16. We'll look at some disorders of pregnancy, some congenital disorders, those ones that are there at birth. I'm not going to do the interpretations other than just take a look at a couple of them and make sure you're seeing them on the page, but you're going to need to spend some time looking at those and familiarizing them with you by yourself. And we're not going to do case studies. In the book, we're not going to do a check-in on the case studies. I took them out. So learning objective number 15, you can scratch off of the list of what we're going to talk about today. We already have 14 learning objectives. I think that's plenty. Quickly, let's take a look at the female reproductive system. We're going to be talking about many of these structures as we go along, so just bear this in mind. We have 2 ovaries, we have a uterus here, the cervix is right here, it's that little opening right there. We obviously have a bladder, we have a clitoris, a urethra, the labia, labia minus and majus, the vagina, the cervix, we just talked about, didn't we? And then obviously we see illustrations also of the rectum and the anus. But let's, and we're not going to talk about this right now. We're going to come back to this, but you can see there is the, this would be the patient's left ovary here. We see these little fimbriae. We talked about fimbriae earlier. Those are like sort of like little fingers that will, can't remember the context of what we talked about. Maybe it was in muscle structures, but fimbriae, those little fingery things, little fingery protrusions that we're going to be able to be seeing in release of eggs from the ovary. The uterus is consistent of 3 primary parts of the uterus. We have the fundus, the body, and the cervix. And we're going to talk about those when we talk about birth primarily. There's the cervical canal, and as a point of reference, the vagina. So if we're looking at this, you often hear of endometrium, and that's the inner lining of the vagina, and the myometrium is the muscle part, not myo for muscle, right? All right, so let's just go back to the beginning here and start. We're going to start at the very beginning. Female reproductive system is different than men. Not surprisingly. What a shock. Um, Females have two primary sex organs, just like men do. Men have the testes, and that's the site of sperm production. And the ovaries are the site of egg production. So that makes the testes and the ovaries, they're called the gonads, right? Those are our primary organs within the reproductive system. The ovaries, we have two of them. You just saw one of them in an illustration. They're held up to the pelvic cavity, the walls of the pelvic cavity, by ligaments that help keep them in place, which is going to be important as we, start to see, um, the entire reproductive system has to be sort of anchored down a little bit more, because we're going to see fetuses develop, embryos and slash fetuses develop in the uterus. So um, ova or eggs are what we find inside. And so men, we have that continuous production of sperm inside of the testes. Happens all the time. They don't even have to do anything about it. Women have their eggs inside of the ovaries, and they're born with all the eggs that they're going to ever have. But they develop one or a few a month. We actually see a few of them sort of develop a month. The goal is to drop one egg a month during ovulation, but often you'll see women can release more than one egg at a time. And so when we're looking at the developing eggs, and I should mention ova is the plural, and ovum, OVUM, that you see there is the singular. As they develop, all of the eggs, just like sperm, have only 26 chromosomes. 23, sorry. When they join together to make an embryo, they become 46, 23 and 23. I can't always add. But every month we see a couple of ova start to, just sort of develop and ripen up and prepare for release. And when they do, they will sort of develop in a little cluster of cells inside of the ovaries, and we'll call that a follicle. And so, at the time of ovulation, usually only one, but it can be multiple ovum get released from the ovary, and everything else stays behind. And any of the eggs inside of the follicle. So the follicle contains multiple eggs. They're all sort of ripening at the same time. They're developing and ripening at the same time. Ripening means they're just getting ready for release, right? Just like a piece of fruit. Once one egg is released, the follicle stays and remains behind, and it will sort of function. That one little sac with those few little cells in there are going to continue to function for a couple of weeks. If fertilization happens, then the follicle, the ovarian follicle, will sort of remain functional for a few more months. And that's sort of the cycle of egg production and release in women. As I said, men have a continuous cycle of gametes, and women have monthly ripening of several, but they release they're intended to release one at a time. Again, doesn't always happen. Let's look at a little bit more about each of some of the parts that we see here. So when we're looking about really the full female reproductive system, it also includes other things. So if we look and we see the ovaries, the egg gets released, and out of the ovary, these little fimbriae here are there, and they'll sort of help when the egg gets released, those little fingers help to kind of sweep it into this uterine tube. And so we see the uterine tube here. The uterine tube is then going to, if fertilization happens, it typically is going to be in that uterine tube. And we want to make sure that the fertilized egg continues to move through the female reproductive tract so that it will not end up in what we call a tubular pregnancy. We don't want fetuses to develop and implant into the uterine wall, into the uterine tube. It's not designed to provide nutrition and growth sufficient. You can see how small it is. It wouldn't be nutritionally or functionally sufficient to maintain a pregnancy. And so as you go along, you see the uterine tube the egg will continue along the uterine tube until eventually it will, if it is fertilized, it will end up being implanted into the uterine wall. And so we saw earlier that the uterine wall has a couple of different layers. The endometrium, that inside layer, is super rich in oxygen and all sorts of good blood flow there. It is designed for to support another growing human being. And so it has a very, very rich blood supply, very highly, lots and lots of blood vessels there to support a implanted fetus. When the fertilized egg is implanted, it becomes part of what we call the placenta. And I think people have all heard of that. The placenta is sort of the feeding sac for the developing fetus. And the placenta will provide all the blood flow and maintain the nutrients needed to support a developing fetus. That's if an egg, when it leaves the ovary and goes into the uterine tube, gets fertilized. If it doesn't get fertilized, that endometrium, those cells there that are all that, sort of, it's been preparing under hormonal influences to develop in a way that it will be supportive of a pregnancy if a fertilized egg implants into the wall. If a fertilized egg doesn't implant into the wall, guess what happens? That those really nutrient-rich cells that line the endometrium get shed, and they get released out through menstruation. So it gets released out in the menstrual blood. And so that's sort of where we end up, and that's kind of the process that we're talking about. Just to be clear, though, and we did see, I think I did talk to you that we have that one kind of structural muscle that we see underneath the endometrium. It was in the other picture, sorry. I was just looking at that. The myometrium, it's a very strong structural muscle that can support a developing fetus. This is where we saw it. So there was the endometrium. It will develop and become very nutrient dense at the time of ovulation to support implantation and quickly developing embryo. And the myometrium will support a pregnancy. It's a strong muscle to support the pregnancy. Let's see, I think, okay, so the uterine tube, we just saw, it has the fimbriae that help the egg get into the uterine tube, and the uterus itself is an organ that nourishes the fetus. And we talked about the three layers of the where did I go? The three layers, the fundus, the body, and the cervix. As I said, I think we talked about this. It has a rich blood, the endometrium, it's that innermost layer of the uterine wall, becomes part of the placenta if pregnancy occurs. If it doesn't, the endometrium gets shed. And so obviously then we can look at the pathway of ovum either to pregnancy or to menstruation. So in both cases, the ovum develops inside of the ovary. The fimbriae, in both cases, sweeps the egg, a single egg, into the uterine tube. If pregnancy is occurring, if there is a fertilized egg inside the uterine tube and it moves into the uterus, the endometrium receives it and the fertilized egg implants into the wall. If it doesn't, an unfertilized egg dies and gets shed along with the endometrium. During menstruation, if the endometrium is implanted with a fertilized egg, it becomes part of the placenta that supports the pregnancy and provides all the nutrition and blood to the fetus that it could ever want. As we continue to look and go back to, I'm sorry, I should have put this on a different one. We see the vagina here, and the vagina is a muscular tube that will help do a couple of things. It will transport menstrual flow from the body as needed, receives the penis during intercourse, but also acts as a birth canal. So that's where the fetus is delivered. And so some of the roots that we see associated with female reproduction, gyneco is for women, not surprised, mens, mens is for menstruation. Like oocyte is for egg. So we hear about it as an ovum or an egg. Ovulo, it refers usually to eggs as well. Ovare, ovario, or oophore are both talking about ovaries. Sulping is for the uterine tube. Utero is for the uterus. Metri is also for uterus. Hystero is also for uterus. Cervico, not surprising, that's the cervix. That's the bottom part of the uterus. It's the neck right before the birth canal. Vagino, and culp or culpo are both for vagina. So we'll see when they do pelvic exams, they use an instrument for colposcopy, so that they can see into the vagina to be able to determine, if they need to get a swab of cells, for example, for pap smears. Externally, so we talked about that there are internal and external organs in the female reproductive system, obviously, male as well. Collectively, the furthest most external genital organs in females is cumulatively called the vulva. And so we saw a picture of it earlier. We saw the labia majora and the labia minora and the clitoris. And so we have the vulva is considered the external genital organs. They have obviously the labia majora is the large outer part of the organ, and the labia minor is so majus or major minus or minora is the innermost little teeny external part of the vulva, and it helps to close off the vaginal and urethral orifices. The vulva also includes the clitoris for sexual stimulation, and we need to remember that we have other things that happen. The vulva has ducts for two small glands that help to provide lubrication for intercourse, things like that. Sometimes there's not a picture of it here, there's a gland externally called the Bartholin glands that are primarily used for production of secretions for lubricants. So externally also we see the perineum. It's the region between the thighs and the external genital organs all the way to the anus. And so during birth, we often see something called an episiotomy. that will it's a surgical release of the perineum um, that will make it easier for childbirth, so that the external genitalia is not torn or ripping of tissues during childbirth. Big baby, small external organs. um, as I said before, mammary glands, breast tissue is not really part of the reproductive system, but we're going to talk about it really quickly. Just the fact that it is a gland, it is um, um, important because obviously infants are, mammary glands provide milk for lactation and nourishment for newborn, up till whenever they want to stop. And so we talked about it primarily in the endocrine system, how milk gets secreted by the glands, the mammary glands, get carried into a duct in the nipple, and the infant is able to feed from the breast. And so we call that an accessory structure. It's um, because it's not part of the reproductive system. It's in addition to. And so some of the roots for female accessory structures, vulvo, it's exterior, right? So it's not part of the reproductive system per se. Episio, both are for vulva. Perino is for perineum. Clitoro is for the clitoris. Mammo or masto are for breast tissue. So let's talk really briefly, and again, I'm sorry we can't do this in more detail. It's just this is how much time we have. The menstrual cycle starts during puberty in a quite period of the period that we call menarche. That's just the first menstrual cycle. Every month thereafter, every 28 days thereafter, um, the menstrual cycle circulates, and it is controlled through the pituitary gland. It's controlled by hormones in the pituitary gland. So just like FSH helped men to develop secondary sex characteristics and production of ultimately testosterone. It's going to be a result of action of FSH released from the pituitary gland for the production of sperm. Same thing, FSH, follicle stimulating hormone. That's why we said in chapter 15, FSH is named after the female action, not the male. So FSH, same chemical, works differently, but it makes the ovum ripen inside the follicle. One of the roles of the ovaries is to secrete estrogen. It's a primary hormone, sex hormone in our body, right? So as the ovum, the eggs, multiple ones ripen inside the follicle produces this important hormone called estrogen, which will then prepare that thin lining inside of the uterus, the endometrium, for egg implantation. So it makes it becomes very nutrient dense, right? It prepares that layer to be for the potential implantation of an egg. Similarly, luteinizing hormone is a secondary hormone that gets released during the menstrual cycle. And this, as opposed to sort of the development of the egg, luteinizing hormone is designed to trigger the release of the egg, the ovulation itself. And it does it triggers the follicle to become what we call the corpus luteum. That is the structure, that's that little sac that's left over, where there's a few of those little eggs that are ripening there, and and then it will continue to function for a period of time if the egg that was released gets um, implanted. What does it do? The corpus luteum will release other hormones like progesterone, and again, some more estrogen. It's going to help with endometrial growth, and it will obviously, if no no egg fertilization happens, the endometrium um, corpus luteum stops after a couple of weeks. It stops releasing these hormones, and guess what happens? The menstrual cycle starts, right? Sort of this cycle of if nothing happens, then if this, then that. Menstrual cycles last, as I said, 28 days. It will, the first day is taken as, we call it, when it's day one. Um, if you're counting the 28-day cycle, it's 1 through 28. Ovulation, the release of the egg, happens on about day 14. And within 2 weeks after that, either the menstrual cycle continues because there was no fertilized egg implanted, or the actual menstruation stops for the development of the fetus. And so this is a sort of a changes in sort of the glands that we see. I'm not going to spend a lot of time on this. You can take a look at this. It's in your textbook on page 514. This really is just showing you that over a period of time, um, so in the uterus, we see the endometrium as estrogen gets released. Here's the cycle, right? So here's day one, nothing has happened, right? Around day 14, when we get to ovulation, remember what I said? We had follicle stimulating hormone and luteinizing hormone get released from those follicles, right? So we see this big peak of release of hormones at the time of ovulation. What did that do? That helped the ovaries to release the egg, and it caused a release of estrogen to occur as well as the secondary hormone progesterone shortly thereafter. You get this sort of initial spike of estrogen just before the release of the egg. And what did it do? Made those blood vessels get nice and big. It brought all sorts of good, healthy growth to the endometrium, and it continued under the action of progesterone and, to a lesser degree, some more estrogen over the kind of the 14 days just before menstruation happens. So makes that endometrium nice and ready for egg implantation. And if it doesn't happen, then you will see this all slough off during the menstrual cycle. And estrogen and progesterone will cycle back down and will eventually go back into this recycling. So this happens every 28 days. It goes up, goes down, around, circles back around, all in anticipation of what's going on as far as the maturing of the egg and the actual egg drop eventually from the follicle. So, just like we have sort of, menstruation as the start of puberty, menopause is not the end of not the end of the world, but it really is the period in time where monthly menstrual cycles, that's hard to say 3 times fast, stops occurring constantly. Usually happens, middle age, 45, 55, sometimes earlier, sometimes later. What ends up happening, because we don't have that cycle of the follicles developing and eggs being kind of primed for release, hormone levels, that estrogen and progesterone, this stuff doesn't happen the way it used to. And so as the hormone levels decline, women undergo sort of all sorts of changes that are, sometimes great, not so great. They start to see things like they'll have hot flashes or insomnia, weight gain, all sorts of things happen during menopause. The egg cells themselves inside of the ovaries degenerate. They're not going to be able to um, typically um, be fertilized at this age. We do see with um, things like IVF, where you can extract eggs from an older female, that you may be able to get them to be fertilized externally. It's not that easy. Um, but it does happen. I forgot, there was just a woman that was like 70 that just got pregnant, maybe within the last 5 or 6 years. It was crazy. Anyways, menopause, the eggs degenerate. And look at the symptomology that comes with this. Um, looks pleasant, doesn't it? Um, Years ago, it was pretty standard practice that they would give hormone replacement therapy. There's a lot of controversy about this. Sometimes they give it briefly, just through menopause, and they call it menopausal replacement therapy. Um, but um, the exogenous introduction of estrogen and progesterone can eliminate some of those menopausal symptoms, um, but there are lots and lots of studies around um, the side effects that come from it, which could include, things like risk of cancer, higher levels of endometrial cancer, uterine cancer. So it's not, there's a lot of conversation about hormone replacement therapy and whether or not to be using um, um, synthetic, or if people should be um, just trying to manage the symptoms another way. Um, they also may see use of antidepressants, lots of mood changes that happen with um, menopause. And the other thing sometimes we see is sometimes things like vitamin E that is topically administered, um, whether it's to eliminate vaginal dryness or just to um, kind of get rid of some of those symptomologies that are associated with a loss of the hormones that we associate with sort of um, the period of time when someone is of childbearing years. So, estrogen and progesterone. You can um, remove some of the symptomology with some external things like vitamin E, but it doesn't really change the biochemical lack of estrogen and progesterone. So it is, everyone should do their own. I'm going to add a caveat: everyone should do their own information, talk to their doctor about hormone replacement therapy before deciding to do or not to do it. Contraception, we're going to talk about 3 different methods. The first is blocking just penetration of the uterus. Sperm don't get into the uterus. They can't fertilize an egg. We can prevent implantation of an egg. So the egg can be fertilized, but prevent implantation. That's sort of those Plan B drugs that you hear about in the um, news and the pharmacy. So blocking, let me just stop back. So blocking sperm penetration could be something like, don't see it, using condoms, or that's probably the biggest one, is using a condom, right? Don't let sperm in. The second is stopping implantation. That's using something like an IUD, or it's using a drug like Plan B that will prevent the hormones from allowing the endometrium to be receptive to fertilization, implantation of a fertilized egg. And sometimes we can prevent ovulation, and that's the quote unquote pill, right? They give um, they give different dosages of hormones, and it will suppress the ovulation. Um, and so the book talks a little bit more about Plan B, and it's a couple of doses of the hormone progesterone that help to prevent implantation. The other way, and we didn't talk about it too much, there we go, is sterilization. Sterilization by either men in the form of vasectomy that we talked about really briefly in chapter 15, or tubal ligation, the same thing in women. Tubal ligation is where, just like in men, they cut and cauterize and, quote unquote, tie off the vas deferens. In women, they they snip the uterine tubes, and it will prevent eggs can be released, but there's no tube to deliver it to the uterus. For um, there's no tube, frankly, for contraception to take place, nor to deliver it to the uterus if it was to be a fertilized egg. And so you can see here the vas deferens from both testes are snipped and cut, and the uterine tubes are snipped and cut, cauterized usually. Okay. The other thing, laparoscopic sterilization, they're just showing you that now. I don't know why they bothered so much to do this, but they can do laparoscopic surgeries now where they make a very, very small incision, and they'll be able to just sort of make the snipping as they need to with very, very small incisions. It's not a big surgery. So a couple of other key terms. The cervix, we just talked about, that's the lower narrow portion of the uterus. We talked about all these: clitoris, contraception, corpus luteum, estrogen, fallopian. We talked all about those. Fallopian tube is the same thing as the uterine tube. Fimbriae, we talked about those. The fornix we didn't talk an awful lot about. It's a little space inside. It's the middle space in between the vagina and the cervix. And it means it's an arch, so it's a little archy shape. It's not a hugely common term. The greater vestibular Vader, no, let me try. I'm getting very tired. Greater vestibular gland. That's those Bartholin glands. Labia major and minor, we talked about, luteinizing hormone, menarche, menopause, menstruation. Okay, we talked about all these. We talked about the rectouterine pouch is exactly what it sounds like. It's a little teeny pouch or a little pocket that is between the rectum and the uterus. Again, not something we talk a lot about in everyday life. Okay, so let's talk clinically what happens in diseases of reproduction. Just like men, women are prone to infections in the reproductive system. Some are sexually transmitted diseases, some are not. Things like genital herpes. So we know that's herpes of the genitalia. And so it's a virus, and so we're going to be considering that. So genital herpes is not curable in men or women. It's very easily transmitted from men to women and women to men. And it's estimated that about a quarter of all people, adults in the United States, have genital herpes. So be careful. They will sometimes you hear them called genital warts. They'll call them genital sores, and so on the external genitalia, you'll see sort of sores and lesions. So what do we see as a result of this? Herpes is it's an infection. So you see things they may feel when they urinate, an itching, a burning, things like that. Very easy to pass along. There's really if there's nothing active, it can still be passed along. So there you go. The biggest issue that women have with genital herpes, though, is that it can be passed from mom to baby through the vaginal canal during birth. So that is something we want to make sure that we avoid. So they will check to see if mom has genital herpes, and if she does, they may opt to deliver through a C-section. The next one is Candidiasis, it's a candida infection. Candida albicans is the most common form of it's a fungus. It's kind of it's a yeast and a fungus. We're talking about the same thing, and it results in an infection, an itis, vaginitis, an inflammation of the vagina. So lots of reasons you can get a vaginitis. You can get bacterial vaginitis. You can get fungal vaginitis, lots of different things. But vaginitis is just inflammation of the vagina. So remember, itis is just inflammation. A lot of itching and the kind of a thick white mucus gets released. So there's symptoms that tell us if someone has candida or bacterial vaginitis, and they should go get treated by their doctor. People should not ignore it. I think that sometimes if people have sort of a metabolic disorder, sometimes even just during pregnancy, but if people have metabolic disorders like diabetes, where they have a high sugar content in their urine, things like bacteria and funguses, yeast really like to live there. That sugar is big nutrient for bacteria and funguses. So a little bit of an infection sort of blossoms out of control, and then they just have to treat it with a antifungal or an antibacterial agent. Pelvic inflammatory disease, PID, is exactly what it sounds like. It's infection that gets into the pelvic cavities of the body. Um, this we see more with sort of, I think of them as more aggressive. I don't know that they really are, but they always seemed worse to me when I hear about them than like a bacterial infection. Yeah, sure, but like things like sexually transmitted gonorrhea or chlamydia are two things that sort of travel a little bit easier from the respiratory system into the pelvic cavities and cause an infection. So that's generally not something you want, but it is treatable with um, antibacterial agents. So it's it's fine. You have to know you get it though. And the last one we see here is salpingitis, which is just an inflammation, again, of the uterine tubes, of the fallopian tubes. A couple of other things we see. Fibroids. People hear about fibroids. Fibroid is it's benign, but it's a tumor inside the um, kind of the smooth muscle in the uterine walls that um, the the muscle wall, right, um, inside the uterus. So it causes a sort of a benign growth, shall we say, and it's pretty painful from what I understand. Um, Fibroids don't really, I don't know that there's great treatment for them. People, what usually sends people to their doctors is they have very, very heavy and prolonged menstrual cycles, maybe some rectal bleeding or some bladder pressure, all sorts of things that are issues. Not rectal bleeding, but rectal pressure, I should say. And what they end up doing is they maybe switch up the hormonal balancing to see if that helps to reduce the um, kind of overgrowth of that myometrium. See if that helps to reduce that growth of those tumors, or, benign tumors, and release some of the pressure from the fibroids. Let's talk about a couple of other clinical aspects or diseases we associate with the female reproductive system. I think probably most people have heard of endometriosis. It's when the endometrial tissue is sort of an overgrowth and it grows outside of the uterus. And often it goes into the ovaries and into um, the tubes. They can all be affected. And so what ends up happening is, sort of normal hormonal triggers get a little out of control. And the endometrial tissue that we know is supposed to kind of grow and develop into this nice nutrient-rich space sort of goes a little crazy, and you get this sort of overgrowth. It becomes very inflamed and um, um, you know kind of painful, and the that smooth muscle becomes inflamed as well. Lots of problems that happens, and so you get that fibrosis, and you get what's called adhesions, where we've talked about before when you're talking about whether it's two organs or something, we have that sort of liquidy kind of those layers in between things that help keep our organs from sticking together. When things stick together the way they shouldn't, that's called an adhesion. Um, and it can cause damage to the tissue itself. So endometriosis, this sort of overgrowth, this inflammation, the fibroids and the adhesions all together can lead to infertility. Um, Results in dysmenorrhea, which is abnormal menstrual cycles, infertility, which I just said, very painful from what I said. They can sometimes get rid of the extra tissue to see if they can alleviate some of the symptoms of endometriosis. And so this picture here shows you all the little places where the extra tissue can grow outside of the uterus. It can be quite a lot. Menstrual disorders, let's go through these really quickly. Um, Typically caused by things like hormonal imbalances, different triggers from the pituitary gland, from the ovaries, from the follicles, but also some systemic things can start to cause some of these things that we see. Um, Things like you know, different kind of things that are outside of the uterus. Even things like menopause can start to cause changes like that. So some of these we start to see as sort of life changes through just aging, and some are just sort of imbalances in our body or other things, kind of a dysfunction of our reproductive system. And so um, oligomenorrhea is too light of a flow. Oligo is low. Menorrhagia, that RRHAGIA, is too much flow. It's sort of, think of like a hemorrhage, right? So too much. Same thing, menorrhagia, it's a very heavy flow. Amenorrhea, A is without, so no monthly flow. And dysmenorrhea is, dys is always that painful, problematic, difficult was the word I was looking for. Whatever the condition is, right? And so dysmenorrhea is painful or difficult menstruation. For obvious reasons, menstrual disorders tend to take place in younger people than older. As you get to menopause, your hormones start to drop, and sort of some of these abnormalities start to fade away. The other one I think people are very comfortable in understanding is PMS, premenstrual, and it's talking really about that second 14 days of the menstrual cycle, where the hormones, your estrogen is high, your progesterone is high, and you start to have sort of lots of symptoms that we associate with people getting their period or just beforehand: emotional changes, fatigue, bloating, headaches. So all sorts of things can come with this sort of cycle of hormones. And sometimes the best way to do it is to, put someone on the pill and they get a hormone adjustment. But also they'll do things, it seems crazy, but they have to put people on antidepressants or anti-anxiety medications. Sometimes natural remedies like exercise, meditation, yoga, things like that to reduce stress in our bodies. Dietary control, taking it easy, really, you got to rest. All of those things can help to alleviate um, um, PMS. It's a real thing. Um, PCOS, a polycystic ovarian syndrome, is also an endocrine disorder. This one is one that affects fertility. And so you end up with very high increased levels of those androgens, right? Those estrogen secretions, primarily. The ovaries get lots of cysts or little growths on them that trigger odd releases of androgens. It makes it so that FSH and luteinizing hormone can't get released and do their job the way they should. So if you're not releasing from the follicles FSH and luteinizing hormones, the things you're not having happen, you're not getting sort of the uterine wall, the endometrium is not preparing for implantation and supporting implantation. You're not secreting out extra, that quick blip of estrogen to help ovulate properly. All of those things release to cause result in things like not ovulating, right? So if you don't release FSH and you don't release estrogen, you don't ovulate, right? So infertility, scant or absent menses, lots of hair growth in places you don't necessarily normally get it. Insulin resistance, we talked about that when we talked about hormone therapy, and obesity. It's very difficult. PCOS, I think they still are trying to really figure out some of the treatment. It's pretty difficult to regulate from everything I've ever read about it. Hormones, drugs, monitoring weight, and trying to maintain that, and even trying to remove part of the ovary to eliminate some of that cystic tissue. Just like you can have cancers in kind of any cells, and we saw that in men, that we had prostate cancer and we had testicular cancer. In women, the endometrial cancer is, we find that in the uterine wall. Unfortunately, it's not always detected by pap smear. It is not just because of the way the test is done. You don't necessarily get to see those cells. But if detected, it's treated usually with either a hysterectomy to take the cancer out fully, or they may do radiation. Sometimes you'll hear something called a D&C, a dilation and curettage. Lots of reasons people get DICs after a miscarriage or something. Someone may get a D&C. It's just sort of a scraping of the abnormal lining cells are sort of scraped away. Cervical cancer, remember cervical was the lower part, the last right before the vaginal canal, and so the cervix. We see this in patients that were infected with human papillomavirus, and so now there's a vaccine that's associated with it. This is definitely diagnosable by the pap smear. And think about it, if so they're doing a brush sweep in the cervix, they can do that. It's often difficult to get into the uterine wall, to get to the endometrium to get a pap smear. And they can do a colposcopy, which is, again, they're just going to be looking at the cells for cervical cancer. They may actually take a biopsy as well. Lots of problems came with this. And so, as I said, HPV virus is found in almost all of the patients that have cervical cancer. And so now they give a vaccine. And I know, again, there's a lot of controversy about it. Again, talk to your doctor if you have people that need one or don't need one. It really has to be done by early, kind of younger ages. I think that once you hit like 20, they don't want to do it anymore. But cervical cancer has, if it's left undetected and untreated, it can be fatal. So we're going to make sure why they do pap smears pretty consistently. Ovarian cancer is another type of cancer we see, and it's cancer of the actual ovary itself. we don't see a lot of, you don't get a lot of warning for this. So it is usually the ovary is pretty malignant by the time they see it. There's a lot of cancerous growth, and it has a pretty high mortality rate. Pardon me. Um, Women often overlook it. They don't really know some of the symptoms, which are things that are really simple, like a change in bowel habits. They might feel bloated all the time. Um, it is, they might feel like a backache, and it really doesn't have any great symptomology. Um, but it is when it's detected, it can be quite difficult. And so treatments, they may take out the ovaries, they may take out the uterine tubes, the ectomy, hysterectomy, take out um, um, the uterus, the whole uterus, right? Then start chemotherapy and radiation. Depends on where the cancer has spread to, what they're going to do with it. They're just going to take the ovary, the whole uterus, the whole reproductive system, basically. Um, Breast cancer is obviously a tumor in the breast. Can be men or women, so don't be, thinking that it can't be. Um, and really, it's the second leading cause of cancer deaths in women, secondary only to lung cancer. Um, just like lung cancer, it rapidly metastasizes. So this is one of those ones that um, it's easy to detect through just palpation. So monthly um, breast self-examination is recommended, BSE, and most breast cancers get found by the person doing the breast self-examination. But there are things we can do in the healthcare system. Mammography is looking at the breast tissue um, through special um, imaging. Um, and so it's probably the most common and most recommended way they do it. They can also do it by ultrasound if it's a particularly dense breast tissue. Remember, breast tissue is primarily fatty, but if it's very dense, they can do an ultrasound to see if they see abnormalities. And if they discover abnormalities, they can do a little punch biopsy just to see it. Quite often, people get nervous because you do find something, and again, it doesn't mean don't follow up if someone gets an abnormal mammogram, but oftentimes it can be just um, a little calcification of the breast tissue, a little bit of calcium kind of um, hardening almost of the tissue. Can also do MRIs, magnetic resonance imaging, to look at the breast tissue as well. Lots of different ways you can look at breast tissue, but the least expensive, least invasive, easiest, fastest is probably mammography. How do they treat it? Mastectomy, remove one or both breasts. They may have to remove some of the lymph tissue nearby, and they are going to check and see if it has metastasized there. Radiation, chemotherapy, and other drug therapies can be quite effective. Um, I think now we know an awful lot about the genetic um, inheritance patterns of some breast cancers. And so, if there's a strong family history, you see now people get genetic testing to see if they're susceptible with the BRCA gene, and will if they do, quite often, if there's a really strong family history, you'll see women or men get preemptive mastectomies just to remove the breast tissue and eliminate the chance that they too are going to die at a very young age from breast cancer. So again, this is something every person has to make in concert with their own physician, but it's an interesting thing how these things are sort of developing. I think we talked about all of these. Endometriosis, leiomyoma is we did not. That's um, but it's that little tumor inside the uterine wall that we call a fibroid. I don't really usually call it. I think I'd only call it a fibroid, but there's a technical name for it. leiomyoma. Let's see. Um, Metorrhagia is bleeding in between periods. Again, not often used. Um, let's see. I didn't talk about a comb biopsy. They'll take tissue from the lining of the cervix, and they call it comb because that's sort of the cone shape of the cervix. Node biopsy we just talked about. Biopsy is just taking a little piece of tissue, um, but they also in a sentinel node biopsy. Sentinel means, do you know what a sentinel is? They're a lookout, right? So a first sign of something, they often call it a sentinel event. And so if they biopsy the nodes, that would be, so if someone has tumor in the breast, they'd look at the nodes closest to the breast to see if there is a tumor there. And if there is, it's a sign, a sentinel, that cancer is spreading. And so that's why they call it a sentinel node. It's a lookout. So you're watching that node to see if any cancer has developed there. Stereotactic biopsy is one using just an imaging to place the biopsy in directly into the place where the tissue where there is something abnormal on the mammogram, for example. And tomosynthesis is just, we saw it with computerized tomography. It's a imaging, it's a kind of imaging. Adnexia, I don't know that we talked about that at all. There's just, it's talking about the extra stuff, the appendices, the appendages, the extra stuff of the of the reproductive system, like the ovaries and uterine ligaments. Areola, we didn't talk about. That's the pigmented ring around the nipple. Graafian follicles is just another term for a follicle that's ready to release or is releasing the ovum. Hymen is a mucous membrane that covers the entrance to the vagina. And the mons pubis is the fleshy area above in the pubic area. This place gets covered by hair during puberty. And we talked about all those. Let's see. Dyspareunia is painful sexual intercourse. Hirsutism, we've talked about before. It's excess hair growth. We saw that with PCOS. Leukorrhea, LEUK is for white, right? So it is a discharge, an excess discharge that's white. That's that sort of yeast infection kind of or bacterial infection that can be found. It's the discharge. Microcalcification, we just talked about that in terms of mammograms. It's often a little spot on the mammogram. You don't know what it is, but they're gonna do a biopsy to make sure it's not cancer. Prolapse, we've talked about prolapses before. Prolapse is sort of um, the dropping of something. And so a prolapse of the uterus is the uterus drops, it goes down. And sometimes they actually will protrude from the vagina. People during pregnancy, very large babies and things, they may have a uterine prolapse. Rectocephaly is a herniation of the rectum. These are enrichment terms. Enrichment terms they were. Okay, we're going to skip those. Please take a look at the abbreviations. BRCA1 and BRCA2, those were the breast cancer genes I was just talking about, those genetic breast cancer genes that are important for people to be tested for if they have a family history of it. DNC was the dilation and curettage we just talked about. HPV, human papilloma. HRT, you hear a lot, human hormone replacement therapy. So look through and make sure that you're familiar with these, especially the most common ones. So fertilization, we're going to try and go quickly through this because honestly, we're getting to, I don't know how much we can do and still keep on track with our time. I really don't want to talk to you for 2 hours. I would love to, but you don't want to listen to my voice. Fertilization, we know what this is. Sperm is released, it's ejaculated into the vagina, and sperm have a little tail on them, and they move, move, move. They head towards the egg, and an ovulated egg in the uterine tube, the fallopian tube, gets penetrated, and we got ourselves a fertilized egg. So you got 46 chromosomes there, and you are good to go. What happens during this process is the nuclei of both the sperm and the egg fuse together, and that's how we get our 46 chromosomes. And at that point, the zygote, the fertilized egg and sperm, travels down through the uterine tube towards the uterus. It's dividing into little cells along the way through mitosis, not meiosis anymore, and it gets bigger and bigger. One cell becomes two, two becomes four, four becomes eight. So every time they double, they double in size. And before you know it, it's a little cluster of cells, implants into the endometrium. Look at that, it becomes an embryo and then a fetus. And so this is just what we were seeing here. And so we're not going to spend any time. I think you guys are smart enough to see this. Let's talk briefly about the role of the placenta in development of the embryo. The placenta is, remember, that's the endometrium, and once the fertilized egg is implanted into the endometrium, it's part of the placenta. The other part of the placenta is called the chorion. That's formed from the embryos. It's actually formed from a little bit of the embryo, and so the chorion and the endometrium form the placenta ultimately, and it has a job. It nourishes the fetus, keeps the fetus alive. We all know what an umbilical cord is. An umbilical cord is how the fetus is attached to the placenta, and arteries bring lots of nutrients to the fetus, the embryo, then the fetus, and there's one vein that takes the blood back to mom. The baby is enclosed in, and there's a great little picture in your textbook of a fetus inside of a embryonic sac. The amniotic sac is what holds the fetus, the embryo first, and then the fetus, and it's filled with a fluid. And the role of amniotic fluid is a couple of things. It provides cushioning for the baby, protects the baby. We don't call it a baby when it's there. Protects the embryo or the fetus. It cushions the embryo or the fetus, so it's very protective. It provides a way to have waste products leave the baby, so a fetus, while it's in utero, will still, take in fluids from the amnion. The fluid is called the amnion. They ingest it and they'll pee it out, out into mom. And so the baby is actually undergoing sort of these developmental stages through its time in the placenta and inside of an amniotic sac. What happens, I'm trying to remember, fetal circulation. So a fetus has, as a fetus develops from an embryo, right? It gets nourished, we just talked about, from the placenta. And so as we said, the fetus is initially, the embryo has this outer layer called the chorion, binds to, it combines with the endometrium, and you get this placenta. And that's sort of that generally, very nutritious place. But inside of there, we have to have lots of things that happen. So first, the the blood between the mom and the fetus takes place through blood vessels, and the blood vessels link directly into the placenta. And so the umbilical cord links the fetus and the placenta to mom. Blood gets carried through the placenta, and it will go through those two first comes in through the two umbilical arteries into the baby. So mom's capillaries, mom's bloodstream, arteries become arterioles, become capillaries. They feed into the placenta, that really bloody, very vascularized placenta. And then the blood from the placenta and those little teeny capillaries feeds into those two umbilical cords, right? Or the two blood vessels inside of one umbilical cord, I should say. And it just carries the blood into the fetus. Mom's blood doesn't really go into the fetus other than to deliver. Its role is not to go into the fetus, and to exchange with the fetus. It's really just to bring oxygen and nutrients from mom to share with the fetus that's developing, right? A little bit of stuff can sometimes pass between mom and baby. Sometimes blood cells if there's a little tear or something, but often we see things like viruses that pass through. We know that HIV, for example, can be passed from mom to fetus. Different kinds of drugs can be passed from mom to fetus, alcohol, other kinds of drugs, right? So we do know some things pass from mom's circulation into the fetus's circulation. So we have to worry about that. Other good things, though, that get passed. There are some protective antibodies that will pass through the placenta and get from mom to the fetus to start to give the fetus some immune protection before it's even born. So lots of reasons that the placenta is an important plays an important role in circulation, not just of blood, but of other elements. So oxygen gets carried in through an artery and taken out in the form of carbon dioxide, right? So metabolic waste products. Fetus doesn't have lungs at this point, right? So so they don't need to breathe to oxygenate their blood, but they have to get oxygen from someplace, and it comes from mom, right? So if that makes sense, fetuses are not someplace where they're breathing anything, right? So we have to have this adaptation of fetal circulation. And so we don't have blood coming into the pulmonary artery like we would in you and I. We would breathe in the red blood cells that left our heart through the pulmonary artery, went to the lungs, picked up the oxygen, and came back through the pulmonary vein. They don't have to. So it is they don't need to pick it up there. But there's a little teeny hole in that septum between the left and the right atrium, the atria, or atrium, single atrium, two atria. There's a little teeny hole there that will help to pass oxygen to the baby. And there's also there's a ductus arteriosus that takes blood from the pulmonary artery right out to the descending aorta, and that bypasses the baby as well. But as it gets close to birth, all of these bypasses, or at birth, the baby takes their first breath, that bypass closes, and the pulmonary circuit from the heart out to the blood, out to the tissues, back to the heart to the lungs, back to the heart, and then gets released out to the tissues, gets established right at birth when the baby takes their first breath or cries and takes in that oxygen the first time. That little bypass part that we see here, pulmonary artery bypass, stops, and true breathing takes place. Mom's out of the picture. All right. Pregnancy lasts about 38 weeks from the time of um, implantation. Oh my gosh, I'm sorry. And about 40 weeks, because remember, ovum are released at about 14 days, so for 2 weeks before that. So about 40 weeks from the last period. Someone's not pregnant for 40 weeks, they're pregnant for 38. Yeah. We tend to think of it in those trimesters, those first 3 monthly periods. During that time, different things take place. Um, it's the first part of it is designed for a lot of early growth and kind of um, placental development and fetal development, all the way to we get to the last trimester when we're starting to see things like development of lungs and finalization of development of the nervous system, and all sorts of things are happening in the last stage of pregnancy. That's another whole topic. But childbirth or parturition happens in 3 stages. And anyone that's ever watched a movie knows this happens. People go into contractions, and those contractions are designed to help the cervix dilate, get bigger, because a fetus is a lot bigger than a cervix. So the cervix has to get big enough to deliver the fetus. The second part is, it doesn't sound as nice, it's the birth of the fetus, or the expulsion of the fetus from the body. So that's really just talking about birthing the baby, right? The baby comes out. Um, and then finally, childbirth doesn't end just when the baby cries and you're like, oh, you have a baby. Nope. You have to deliver the placenta and all the extra fetal membrane. So those um, contractions do a couple of things. The contractions will help deliver the fetus and the placenta and all the excess fetal membranes, right, that we need to get rid of. Um, but the placenta also, the contractions also do other things. The contraction also helps um, control bleeding as the fetus is born. It helps prevent bleeding um, and keep mom alive. um, Two terms that we talk about. So gravida refers to a pregnant woman. So prima gravida is like the first pregnancy, and para refers to a woman who has given birth. Um, so if it's something para gravida, it's right after they gave birth, right? Um, let's see. After Actually, during childbirth, during that third stage of childbirth. Um, Actually, I take it back. Starting with labor, lots of things happen. Um, we don't necessarily know all of it, but one of it is going to be the release of the hormone oxytocin. Oxytocin was one of the ones that was stored but not produced in the anterior, posterior pituitary. I'm sorry, I am just tired as can be. And it is designed to do a couple of things. It's designed to um, help to, um, it's designed to help oops, we're going to go back here, begin the contractions of childbirth. And so I forgot to mention oxytocin earlier. As we move on, though, from pregnancy and birth into what happens afterwards, again, this is not exactly um, reproduction related, but it is, and that is lactation. Um, Prolactin also is released from the pituitary, the anterior pituitary. If you remember that one picture that we saw, the anterior and the posterior pituitary, that everything but FSH and LH were produced and released from the anterior pituitary. And prolactin is not surprising, one of the hormones that's going to begin lactation. And so lactation is just the secretion of milk. And so a couple of ways that lactation begins. One is the anterior pituitary is triggered to release prolactin, but also hormones from the placenta will trigger it as well. And so a combination of hormones signal to the body to release milk. And so you have that first stage um, that is oxytocin, secondary role of oxytocin in addition to causing contractions. It also is to assist in release of milk. And so you get that release of oxytocin, and they call it a letdown stage. And the milk sort of starts to be able to be drained out of the breasts by suckling. And so the first few days, the baby gets really, really highly nutrient rich, lots of antibodies and good stuff in the um, early product that's called colostrum. Colostrum is a little bit different than milk, but it's very similar to milk, but it's a little different in that it has those protective antibodies, for example. It's very nutritious for a newborn. Um, but it is um, very good. It's great for nutrition, but it's also great for the first few days of a baby, just giving it kind of the extra boosts of nutrition and things like antibodies that it needs. And roots pertaining to pregnancy, amnio, I'm going to look and see because we're going so late. TOC or TOCO is labor. Dystocia is a difficult labor. Nate or nady is a newborn. I think we've all heard of a neonate before. Um, and these are more key terms. Amniotic APGAR score. We didn't talk about that. When an infant is born, they immediately take the baby and they rate their physical condition on a scale of 1 to 10. I thought it was 1 to 10. I could be mistaken. Let's see. 1 to the test is, oh no, the maximum test is a 10. I'm sorry, that's why. So they will rate different physical conditions as either a 0, 1, or 2 at different intervals. And so they'll look and see how's the baby's heart rate, how's their respiration, how does their color look. And there's objective scoring for this. And so ideally, a newborn will score as like a 10. But certainly, as we start to get a little bit lower, it's still fine. Really want, though, to an infant who doesn't have a very, very low score. If an infant is born with a very low APGAR score, they'll be taken off to the neonatal intensive care to get some supportive treatment. Figure out what's going on, and we'll give some supportive treatment to the infant. APGAR score. We talked about gestation. Zygote is just the fertilized egg. A gamete is either the egg or the sperm. The zygote is the fertilized egg. All right, we're going to skip poor Abigail from the textbook. I'm telling you, we are this is running very late. I'm going to refer you back to the textbook to read about the conditions associated with pregnancy, and I'm going to skip this here. You certainly can read through it now. I just think it is very, very, very late, and most people know this. I'm going to tell you just a couple, really in the briefest detail. Infertility, we know lots of reasons for infertility, right? We talked about a bunch of them. We talked about PCOS, we talked about hormonal issues, we talked about amenorrhea, right? Ectopic pregnancy we talked about. I'm sorry, we didn't. We talked about tubal pregnancies, where a pregnancy, the embryo is or the egg is fertilized inside the tube and it doesn't progress further down into the uterine wall. That's a tubal pregnancy. An ectopic pregnancy is a larger concept of it. It usually is tubal, but it can be outside of it. And it's any place where the egg is fertilized outside of the uterus and develops outside of the uterus. So most eggs are, in fact, fertilized in the tubes, but they move to the uterus. If they are, again, just implanting any place and doesn't get into the uterus to implant into the uterine wall, we call it ectopic. So I guess I'd say all tubal pregnancies are ectopic, but not all ectopic pregnancies are tubal. And so this you can see, this one they had one that was in the intestine, right? It's, yeah, or inside the uterine tube, inside the ovary, inside the cervix. You're not technically in the uterus. The cervix is closed, right? It's the lower part of the uterus, but it's not in the uterine wall that we expect. So lots of places that pregnancy can occur, but it's not sustainable. There is preeclampsia, is high blood pressure during pregnancy, hypertension. We'll start to see oliguria, so sort of reduced amounts of urine, protein in the urine, edema, lots of swelling, sudden weight gain because of all the swelling. And so because you're swelling, your tissues are retaining all the fluid, you end up with that really a lower amount of urine being produced every day. And protein, just because of a lot of reasons, part of some pressures on the kidneys, high blood pressure. Last week when we were talking about the kidneys and how the glomerulus filters blood. When the blood circulating through the coils of the glomerulus is under very high pressure from hypertension, the filtering system doesn't work the way it's supposed to, and things like protein that shouldn't be in our urine in high concentrations gets pushed right into the ultrafiltrate that becomes the urine. So you'll see protein in the urine as well. It can lead to very difficult and what am I saying? Difficulties in the pregnancy just prior to delivery, and can potentially result in fetal death. Abortion is loss of an embryo before the 20th week. A spontaneous abortion is a miscarriage. So abortion doesn't always mean a surgical removal or a procedural removal. It can be a miscarriage. Causes of abortion: poor maternal health, really can't support it, bad hormonal balance. Again, if your hormones are not in balance, you're not going to support a pregnancy. They call it an incompetent cervix, one that doesn't support a pregnancy. Tumors, things like that. RH incompatibility. This is sort of this one, and this is one of the ones I did when I started. I wanted to just stop and talk about. And so RH incompatibility, people that know their blood type, you're an A, B, or an O blood type, and then you're positive or negative. That positive or negative is that RH. The issue comes up when mom, so anytime you or a person is exposed to something foreign, doesn't belong to them, then they can develop an antibody against it. So we saw this during COVID. People that have been exposed to COVID or got the COVID vaccine, they developed antibodies to COVID, right? Same thing can happen when a mom is pregnant with a fetus. Dad has a positive blood type, O positive, A positive, B positive, AB positive, but mom isn't. So baby may be positive and inherit that from dad. But mom is carrying the baby. And so mom, if there's a little bit of exchange of mom and baby's blood, mom may make antibodies. That says mom's body may make antigens. No, mom's body may make antibodies as blood crosses the placenta, and we call it, what ends up happening is mom's antibodies go to the baby, and the baby gets um, a hemolytic disease. Antibodies, when they bind to the thing that they're looking for, like when antibodies against COVID bind to cells containing COVID, there's one goal for that antibody, your body to do, and that's to kill that cell, even if it's your own cell. Same thing happens if you have a mismatch of um, blood types, including this Rh blood antigen. Um, your your immune um, your immune system is triggered to target the cells that contain that foreign thing. And so mom's body makes antibodies against the baby's blood, and remember I said earlier, blood, some antibodies cross the placenta. Well, there you go. So baby can be born with what's called hemolytic disease of the newborn, sometimes hemolytic disease of the some hemolytic disease of the fetus in newborn, HDFN when it's a fetus, or HDN, and the baby may need a couple of things. Baby may need a little transfusion. The baby may get a little bit of jaundice, a little yellowing of the skin. Usually it's not that bad, but what they do have to do is they have to treat mom to make sure that um, if she hasn't yet developed antibodies, that she doesn't. Um, and she doesn't want to develop antibodies because not for this baby. This baby is generally going to be fine. The first time mom gets exposed, your immune system isn't that good. But the second time mom gets pregnant and has a baby that's Rh positive and she's not, um, her immune system will kick into overdrive, and the second pregnancy and any subsequent pregnancies are at high risk for miscarriage. So they want to give they want to give a mom that has been um, pregnant with an Rh positive baby um, um, a drug called Rogam that will help mom not produce new ones. If the baby did get some of the mom's antibodies, they can actually give um, um, they can do a couple of things. They can give mom during the pregnancy some antibodies that are against the Rh factor getting into her blood, but they can also treat her. They can treat the baby afterwards. Placental abnormalities, placenta previa is one where the placenta doesn't attach to the uterus, it attaches like near the cervix. High risk of it kind of tearing as the baby gets too big. Placenta abruptia is when you really get a separation of the placenta totally from being attached to the walls, and causes a massive hemorrhage. That's really bad. Um, Often seen in older moms. Mastitis, again, not really necessarily reproductive system, but it's inflammation of the breast. Usually happens when mom is just first starting to breastfeed, and it's a bacterial infection. Congenital birth defects, you either inherit them, family disorders, right? You get them through family to family, but often they're something happened while the fetus was growing. So both are congenital. They're both at birth, with birth. So those genetic mutations, the ones that are inherited from family to family member, um, is, we call them genetic issues. They will really usually change some of the gene products that our body produces, um, and make something not work quite right. I'm trying to think of some. I'm sure yeah. Let's see. No, they didn't have it. Sorry. I'm trying to think of one off the top of my head. Congenital disorders known as birth defects, things like, oh my gosh, why can't I think of one off the top of my head? Um, I'm thinking of a lot of diseases that are genetically based, but they don't call them birth. They don't call them birth defects. Oh, something like muscular dystrophy is one. That's a congenital disorder. Goes from um, parent family hemophilia, blood clotting disorders, something called Fragile X syndrome. Um, those are all genetic disorders. Um, Cystic fibrosis is a gene mutation. Um, Others are things that just happen during fetal growth, things like Down syndrome, where um, baby is born with an extra chromosome. Um, so things like that. Um, there's either genetic mutations or kind of a change in the number of structural chromosomes. Um, and oftentimes parents don't know that they have this family history because they've been having people that are what I call carriers. They have the gene defect, but it doesn't manifest itself. And then they have a child with someone else who's a carrier, and whoops, um, that silent genetic defect that mom or dad didn't know they had, automatically you get two of them, one from one chromosome from mom, one chromosome from dad, and then you got a pair, and you got yourself a gene defect. So um, let's really look just at the last couple of these. I'm sorry to say, tetragens are there are different kinds of malfunctions that happen in a fetus. Things like infections, like bacterial infections, like rubella, um, herpes simplex, right? The herpes disease, things that are passed from um, often from either person to person or sexually transmitted or blood to blood, can go from mom to baby. And so teratogens, I'm sorry, um, are things that influence the fetus's development. And so, as I said, some can be infectious things, syphilis, you don't want to be getting that. But also, we see it with babies born with fetal alcohol syndrome, babies that have been exposed to drugs in utero, exposed to chemicals and radiation. All of those things can cause different kinds of defects and malformations in babies, things like cleft palates or um, things like um, anencephaly is one we see. We associate a lot with sort of chemicals and drugs and alcohol, um, that babies born without a brain. Um, these are just some examples of them. Some of the developmental disorders, not all from difficult things. Sometimes it's things that are like spina bifida is an atresia. It's an absence or a closure of the spinal column, and that's just caused. That's not caused by um, um, any mom doing anything wrong or dad doing anything wrong. It just is it's a birth defect. Anencephaly, we just talked about cleft palate if you've ever seen one. So there's things we can see like that. Spinal defects. This is a lot. How do we diagnose it? Well, when people, when mom goes and gets an ultrasound, um, prior to birth, they're looking for congenital defects. Yes, it's great to know the gender and the sex of the baby, but it doesn't mean anything. They may do an amniocentesis. They take a little bit of amniotic fluid, and they'll look for genetic defects there. Or a CVS, a chorionic villus sampling, where they'll take a little bit of that chorion, that little bit of the fetus, and they can take a little bit of that chorion from the placenta and check and see if there's any genetic defects there. A few more key terms. I think we talked about all of these. I think so. We've talked about all these before, and those are enrichment terms. So I know this was fast. I hope take a look at your abbreviations. I hope it at least helped a little. I know it was very fast. Take a look at the textbook. I'm really fearful of how long this narration already is, not because of me, but because I would rather see you look at it and listen to it a little and get at least a broad sense of um, the female reproductive system, childbirth, etc. And so the health profession that was spoken about in this chapter was um, um, in general related to female reproduction, and we talked about certified midwife, nurse and midwife, um, professional midwife, a douala, and so a certified nurse midwife is someone who does both, nursing and midwifery. They provide, care to the mom prior to birth and will often help with the birth. Midwives are really only exclusively associated with pregnant women and helping them give birth. Um, a certified professional midwife really doesn't have a college degree, but they have been trained independently, person to person, to be a midwife. And a doula is a birth assistant who helps during pregnancy, through labor, and even into childbirth, after childbirth. Anyways, this is our very long conversation about the female reproductive system. Oh my gosh, say look at that, an hour and a half.